name is Magdi Elsallab. I am the Director of Process Development at the Cellular Immune Therapy Program. I'm also the Director of the Cellular Therapeutics and Transplantation Lab at the Mass General Cancer Center. And just a brief background, I know most of the people here are familiar with CAR T cells, but I thought let's give a brief background on how CAR T cells were developed and where we are right now. So as you can see here, CAR T in its native form, or the form that was developed, usually has an extracellular antigen binding domain, linker or spacer, and then a transmembrane domain, and then we have the intracellular domains. And the idea is to polarize the specificity of T cells using the antigen binding domain that is able then to transmit the signal into the immune cells and activate the T cells, also initiating differentiation, proliferation, and cytotoxicity. And this is a very nice timeline that was published by Crystal Makel and show like how we are here right now, from the attachment of the single chain variable fraction to the TCR and TCR alpha and TCR beta, to the first generation of the CARs that were that had only the CD3 zeta as the signaling domain, and then the development of the second generation CAR, including the 4-1BB and the CD28 co-stimulatory domain, and then the testing of these domains in the preclinical settings, moving to the clinical, moving then to the approval of 6 CAR T cells for various indications in liquid tumors. But then where we are right now regarding the engineering of the CAR and the design of the CAR T cells, we moved away, not to say that it's not effective, but now we're exploring other antigen binding domains, including nanobodies, cytokines, and other ligands. And we have gained more understanding of how the linker and the transmembrane domain can affect the signal transduction and the activation of the T cells. And then also we started to explore other co-stimulatory domains, trying to polarize and differentiate T cells to desired phenotypes. And there are actually now approaches to screen for multiple signaling domain in competitive models to highlight which signaling domain or which combination of signaling domain can produce some desired effects. But then also we started to think, how can we enhance the function of the CAR T cells beyond the engineering of the receptor by including other abilities, such as including bispecific antibodies or enzymes, or secreting antibodies or other ligands or receptors. And just quickly, for the manufacturing of the CAR T cells, this is usually starts with the apheresis material that then can be further purified using illustration or moving directly to the magnetic cell separation. And then the activation of the T cells using either antigen-presenting cells or beads or antibodies. And then the introduction of the CAR usually is achieved most commonly using viral vectors, but also there are now methods to manufacture the CAR using non-viral approaches. And then once the introduction of the construct is achieved, the T cells can be expanded to the desired numbers and then formulated and cryopreserved. And as most of you know, this all can be done in a closed, functionally closed, semi-automated fashion in the CliniMACS Prodigy machine. Moving back to the outcome of the CAR T cells in hematologic malignancies, we see durable response in recurrent or relapsed ALL patient, and this is from a meta-analysis that we conducted. As we can see, the 5-year survival of patients, overall survival of patients with recurrent or relapsed acute lymphoblastic leukemia is 44.1%, and the event-free survival is 35%, keeping in mind that those patients usually had much lower survival rate on the standard of care. But then when we look at this picture in the context of solid tumor, we don't see similar outcomes. The overall response rate in solid malignancies is around 20%, and this is from another meta-analysis that looked into the solid and hematologic malignancies. And while in the same meta-analysis, the overall response rate in heme malignancy was 71%. This does not mean that there's no silver lining. The two papers that I am highlighting here showed some positive results for CAR T cells in neuroblastoma and also in gastrointestinal cancers. But what is the issue when utilizing CAR T cells and targeting solid tumor? I would say for hematologic malignancies, the barriers are much less that you can get a direct contact between the CAR T cells and the malignant cells without much barriers, while in solid tumors, you have to overcome several barriers, including barriers for infiltration, because you have dysregulated adhesion molecules in the blood vessels feeding the tumor, and you have the extracellular matrix that the cells needs to penetrate. And then you have several immune inhibitory cells, such as Treg cells and tumor-associated macrophages. But then also you have the fibroblasts and the inhibitory cytokines that are usually available in the tumor microenvironment. Also, additionally, you have less nutrients and competition on the nutrients between the CAR T cells and the malignant cells. And on the level of the malignant cells, you see different ways of resistance to CAR T cells, including the absence of co-accessory molecules that are necessary for the function of the CAR T cells. You see also that there is an antigen loss on the recurrent or the scabbing tumor cells. Also, we have the upregulation of inhibitory molecules such as BDL1 or CD86. And then there is a dysfunctional apoptotic machinery that affect the ability of the T cells to induce killing of the tumor cells. And to this extent, I wanted to share our experience of how we thought of overcoming such challenge. Before arriving to this product, CAR-V3 Team E, our team tested CAR T cells targeting the EGFR variant 3 in glioblastoma, and the patient in the phase 1 clinical trial had recurrence of the glioblastoma that were negative for the EGFR variant 3. So the idea was to engineer a new CAR T product that is able to secrete a bispecific antibody or a T cell engaging antibody molecule that target the wild type EGFR and the EGFR variant 3. And the beauty of this is the T cell or the CAR T cell can deliver the bispecific antibody in a local regional manner, which is important since EGFR is also expressed on other normal tissues such as the skin. And as you can see here, this is the construct that was used later on in the clinical trials, which consisted of the EGFR variant 3 CAR, and then the team which has a side targeting the EGFR, and then the other side targeting the CD3, which mediate the engagement between the T cells and the cancer cells. And as you can see here, this is results from an orthotopic glioblastoma model that when you of a heterogeneous cell line that contained both EGFR variant 3 and EGFR wild type cells. When injecting CAR T against the EGFR variant 3 with an irrelevant team, you see that the CAR T is not able to control the tumor, while when you introduce the CAR T with the team, you see the ability of the T cells to control the tumor. And what was interesting in this work that was conducted by Dr. Brian Choi at his time in the Moss lab, that we observed that the team was not only able to polarize the CAR T against the EGFR, but also it was able to recruit the bystander T cells that are also infiltrating the tumor and repolarize them to be able to target the tumor and actually induce cytotoxicity on their own without the CAR T. And in some beautiful work that has been done also by Brian, he shows that even using the supernatant that was derived from the CAR T cells and mixing this with the bystander T cells, they are able to kill without the CAR. And as you can see here, in those immunofluorescence images, you can see the M-cherry is the transduction marker, while the biotinylated EGFR is the marker for the team. And on the red cells, you see some yellow dots. Those are the bound team to the CAR T cells, while on the green colored sphere here, this is a bystander T cell that was coated completely by the team that is able to repolarize the cell to target the tumor. And this elegant work has led to the start of Incipient, which is a phase 1 clinical trial for the CAR Team E in glioblastoma that had a safety run-in arm 3x3 design, and then the plan is to open 2 arms afterward for EGFR, recurrent EGFR positive and EGFR negative glioblastoma. And then once completion of those 2 arms, there is a 3rd arm for newly diagnosed, not recurrent glioblastoma that is either positive or negative for EGFR. And this is the manufacturing process that was used to generate the CAR at the CMCF, the cell manipulation core facility at Dana-Farber, which is across the street. We start at day 0 by selection for CD4 and CD8, and then activation. And then on day 1, we do the viral transduction. And then from day 2 to day 6, we expand the T cells to the relevant number. And then we harvest and QC on day 7. And this is the sum of the testing that we conduct on day 7. And we see the transduction efficiency for the first 3 patients that were treated in the trial, along with the vector copy number for the T cells. And also, we evaluate the amount of EGFR that is bound to the surface of the CAR T cells. And we can see that almost all the T cells are coated with the team at the end of production. This then gets formulated and cryopreserved and then gets shipped to us at the CTTL. We then thaw the product, reformulate in a CSF compliant media, and then infuse the patients. And this is the results from the first 3 patients. And as we can see here, there is a dramatic response to the CAR T cells for the product. You can see here the enhancing lesion. This is pre-infusion, and this is post-infusion. You can see the decrease in the enhancement in the images. And this is also, I forgot to mention, that this is delivered locally through an Ommaya catheter that is implanted directly into the tumor to deliver the T cells locally. And as we can see again in patient 2 and patient 3, there is an immediate response to the CAR T upon implantation. There was also some side effects, including very low-grade CRS and grade 2 ICANS, and then grade 2 TIAN, which is different. It's also neurotoxicity, but is mediated mainly by the local inflammatory process that happens by the CAR T upon delivery. This is some of the immune monitoring that is conducted for the patients. And this is a CSF sample on the right from subject 2. And as we can see, when gating on the CD3 positive, CAR positive T cells, and then looking onto the amount of the team that is bound to the T cells, we see that most of the CAR T cells inside the patients are still has team molecule bound to their surface. But also the interesting that when you see the CAR negative compartment, you can see that the locally secreted team is bounding to the surface of the bystander T cells inside the patients. We also monitor for the vector copy number, the CAR positive T cells, and the team positive CD3 cells in those patients in the CSF and the peripheral blood. And we see some expansion, but still we are working to acquire more data in order to work on the correlative studies for this data. This is like very, very briefly our story, and I wanted to say that this all happened from A to Z locally. So from the start to the beginning, we do everything here. The discovery, the process development, the manufacturing, the immune monitoring, the clinical team, everything happens here, which I think raises the question how we can expand this model and how we can bring this model to other, to a broader patients and to improve the patient access, which has been an area of interest for me. And there are multiple solutions that we can think of. We have the cellular therapeutic and transplantation lab here that I believe we have the capability of producing our CARs, but then also there are local GMP facilities and academic GMP facilities that can be exploited and leveraged to produce the CAR T cells. There are others that are working on mobile manufacturing units that can actually translocate and manufacture the CAR T cells or the immune effector cells, depending on the supply and demand. But I think the regulatory framework remains one of the biggest challenges when it comes to this. We have seen advances happening in this area, particularly in Europe and in Canada, but it's still, we see some, not pushback, but there are some hurdles on implementing such models in the US regulatory and reimbursement system. But then there are the questions of whether single centers can apply for biologics license application based on multi-center trials that are managed by a central entity, or should be there an entity that can drive the development forward and apply for a biological license and hold this biologics license and manage multiple sites across the states. And this is, again, we thought of this question and we were thinking, what is the infrastructure that is available in the United States that can actually serve this purpose? And the fact accredited cell processing facilities can be a starting point. And we looked at the number of institutes in the United States that are approved, that has the accreditation for immune effector cells, but also has the accreditation for doing a more than minimal manipulation manufacturing. And we have at least 28 facilities in the United States right now that are associated with a clinical program that can perform an immune effector cell manufacturing and administration and clinical monitoring. And this is from a survey that I conducted during my time at the Harvard MIT Center for Regulatory Science. And we looked at what is the available or what are the practices and the available infrastructure that can serve this purpose. And not very surprising that most of the facility for minimal manipulation and more than minimal manipulation utilize automated systems and are familiar with utilizing tubing sets and handling liquids similar to what we see in manufacturing of more than minimally manipulated products. But also we see when we asked about the interest of those facilities in applying a point-of-care manufacturing approach, we see in the first question here that most of the facilities think that fact-accredited establishment can be a suitable place for manufacturing of immune effector cells, and most of them are interested in applying this approach. However, they were split across the board of whether they have the sufficient support to conduct this kind of manufacturing activity. And with that, I would like to thank you for inviting me. I would also like to thank the team behind this kind of development, the MOS lab, the immune monitoring lab, the process development lab, and we have the cell therapy lab, the CMCF lab. We have all the labs around us that are working to deliver transformative treatments to patients that we hope to see getting closer and closer and being available for other patients. Yeah, thank you.